So, the agenda for today, and again, this is really more an opportunity for you to get information and to ask questions. So I'll go through the slides, but feel free to have questions at the end of this presentation. But hopefully the slide presentation will provide some background on the vaccine itself, as well as where we stand at this point. Next slide, please. So we'll start off with the COVID-19 vaccine overview. So we were excited. I was actually waiting for the vaccine to arrive at 7 o'clock in the morning in Dover, but the Pfizer vaccine did arrive in Delaware earlier this week. There were 2 different shipments that came out, again, based on how the orders were placed. But we, within the Division of Public Health, received our vaccine on Wednesday, and we've already started vaccinating people within the state. So some key information, the EUA, or the Emergency Use Authorization process, is a process that was developed by the FDA to try to get new medications, interventions, tests out as quickly as possible. So it doesn't go through the formal FDA approval, but it does go through an EUA process, which still ensures the safety and effectiveness of these new devices, medications, and so forth. And the CDC accepted approval recommendation on December 13th. There are 2 vaccines that we're eyeing on right now. The first one's the Pfizer, as I said, has already been approved by the EUA. It is a messenger RNA vaccine. The second vaccine that we are eagerly waiting is the Moderna, which is also a messenger RNA vaccine. The efficacy looks pretty good for both vaccines. The phase 3 trial efficacy at 95% beginning 28 days after the first dose, and efficacy is consistent across ages, gender, race, and ethnicity. The observed efficacy in adults over 65 was over 94%, and this was great news. We were concerned that the efficacy would not be as good in adults over 65, given not as strong of an immunity system as you would see in the younger population. So we were excited seeing these numbers above 90%. Next slide, please. So I mentioned the Moderna. So the meeting, the FDA committee met
Nancy, if you want to watch this, we can just watch together.
The EUA information, as I mentioned before, on the Moderna, that the FDA committee met on
Thank you.
December 17th.
Thanks, Cindy.
I'm sorry, is everyone on mute?
Yeah, folks, if you're not on mute and you're not speaking, please mute. Thank you.
Thank you, guys. And that's okay. This has been weird times, but I feel like I'm becoming a pro on Zoom. I can use Zoom like 0 times before all this happened. So I'm getting better. Thank you very much, guys. So the Moderna vaccine is expected to hopefully be approved sometime between December 17th and 21st. There is an internal vaccine group within FDA that's going to, should have met already today with final recommendations, and then it will be reviewed once again by the CDC. So looking at the clinical trials, the phase 3 trial efficacy was 94.1%, and the preliminary research suggests broadly consistent safety and efficacy across all evaluated subgroups, which is very similar to what we saw with Pfizer. So in Pfizer, there were about 40,000 volunteers within the clinical trials, and for Moderna, it's about 30,000 people within the trial. So a good sizable number of people, but as you can imagine, our plan is to vaccinate millions and millions and millions of people. So we do anticipate maybe some additional side effects that were not picked up initially during the clinical trials. So if everything goes well, we hope to get the shipment. Oh, thank you, Steve. Thank you very much. I'm so happy to hear that about an hour ago. So it sounds like it did go through the FDA committee as approved, and we're just waiting for additional review by other agencies and groups. So thank you, Steve, for that update. The expected shipment is as early as December 21st. We have already placed our order early because we wanted the vaccine in the state as soon as possible. And that's what we did as well as Pfizer. So we were ready to go once we heard that the vaccine was approved for use. AstraZeneca is the next one in line that we anticipate to go through the process. The efficacy is 70% during the phase 3 trial. And there are some mixed results that showed that potentially that the higher dose group may actually get lower efficacy. And this was something that was unexpected. So we're waiting on more information on really what the appropriate dosage is for AstraZeneca. And we are likely that it will complete its clinical trials and go through the similar approval processes as the other 2 vaccines went through. So again, just as a kind of general information, one of the comments I've received is that the concern for the safety aspects of these vaccines, because they appear to kind of go through the processes so quickly. And I want to assure people that it completely went through the EUA process, and that really the time was saved in other areas outside of guaranteeing safety. So for instance, some of the bureaucratic red tape processes were shortened to try to get this vaccine as quickly as possible. And also we simultaneously saw the manufacturing phase and the distribution phase occur during the review phase. You can imagine if there weren't such an urgency to get this vaccine out, that most of the time we will go through the review process, wait for the approval, and then commit funds to manufacture and distribute. But all that happened at the same time, and that really cut out a chunk of the, I guess, the time process to get the vaccine out to market. Next slide, please. So what's different about the mRNA vaccine? So many people probably are not aware of the mRNA vaccine. It is not a new technology, but definitely it's new for this vaccine. This technology was available for quite some time, but never really came to market. So we're familiar with DNA vaccine, and it is very different from the RNA vaccine. As you can see in your picture, both types of vaccines, the DNA and the mRNA enters the cell. But one clear difference is that the DNA goes into the nucleus. And the reason for that is that's where all the proteins and the materials and the components are needed to translate the DNA strands into a messenger RNA. So you can see there with the DNA vaccine that once the mRNA was produced, it leaves the nucleus, and that's where proteins are created. And we basically cut out that transcription process, and the mRNA is just introduced into the cell, and then viral proteins come about. So another question asked is whether this mRNA virus impacts DNA, and the answer is no, because as you can see here, it never enters the nucleus. So there's really no suspicion that it does mess with the DNA within our cells. So then you can see here, that's how the viral protein presents itself, and that's how an immune response comes about. So kind of like the same thing either with DNA or RNA, but that one major difference is that the DNA vaccine, it enters the nucleus, whereas the mRNA does not. Next slide, please. So next we're going to talk about the vaccination planning timeline, and this is very fluid, so we'll keep going. So that's my disclaimer for this section. With the vaccine's arrival, many are wondering when they will be able to receive it. So everyone realizes that we're not going to get enough supply to get everyone who wants to be vaccinated at one shot. So we are using a phased approach, and I do want to emphasize this is a phased approach. It's not a priority approach. This is something that we saw during H1N1 when we developed priority groups. And some of the feedback from the medical community, which was really helpful, was that they felt they were restricted on using the vaccine outside those priority groups until we officially went into that next phase of priority groups. And there were some reported waste of vaccine, and that's something we definitely don't want to see. So we want to take advantage of the opportunity that if you happen to have vaccine left over, we don't want it wasted. So please find someone to inject. Given the very limited supply, it's very important we use up all our supply. And we'll talk more about the limitations with each vaccine. And there are reasons why we're so concerned about waste. And there are challenges with the vaccine itself that impacts how we're going to allocate this vaccine. Next slide, please. So this is something that we developed, and you can see some of the phases are proposed, but the phase 1A has been formally approved by the director of Division of Public Health, which is Dr. Carol Rattay. And the phase 1A is very similar to what the Advisory Committee on Immunization Practices agreed upon. So we are ranking, I hate to use the word ranking, we are phasing the first doses to healthcare personnel as well as long-term care residents. And that's what you can see here on this pictorial. Well, no, I just want to mention that you notice that the phases are overlapping, and I think that's key from our perspective. So we are not planning on vaccinating everyone in phase 1A first before we start with 1B. And there are many reasons for that. And I think the primary reason, as I mentioned before, is we want to reduce waste. So I can imagine that, for instance, if we are vaccinating a group of healthcare providers and something happened and we have doses left over, and there's no one else in 1A available to vaccinate, I want to make sure that providers have the ability to vaccinate at least phase 1B. You also can imagine from an operational standpoint, if we are distributing vaccine to, let's say, a practice, and the practice used up all of the needed doses of vaccine for staff, and you have a vaccine left over, it kind of makes sense that we start focusing on patients. So there are many reasons why we like this overlapping approach, and that's the approach we're going to use in this case. So there are opportunities to start off with phase 1A, and then if everything goes well, that we can anticipate starting phase 1B around week 3 or 4, even 5. And right now we are proposing that phase 1B should include the following: 2 major groups. The first group is those that are considered high-risk essential critical infrastructure workers. But then the second group, we're looking at those at the highest risk for burden for COVID-19 disease. So that includes hospitalization and death. If you are familiar with ACIP, they actually divided this group into two. So they actually have phase 1B as essential critical infrastructure workers, but then they have phase 1C as those with the highest risk for burden, which includes age greater than or equal to 65, as well as those with certain chronic medical conditions. So we are proposing we're going to combine both groups together into one because, our concern is that how can we consider those are seeing the worst part of the disease considered a phase later than those that potentially may not have those risks, but are also critical to essential infrastructure. ACIP is still deliberating on phases 1B and 1C. So we are waiting for their recommendation, but we are kind of leaning towards this until we get more information. Just to let you know as well too, we are fortunate in this state to have a ethics advisory group, and we did run these phases through our ethics advisory group, and our advisory group did formally recommend phase 1A to coincide closely with ACIP's recommendations for phase 1A. Next slide, please. So kind of going into more detail what phase 1A is. And again, it's really for healthcare personnel as well as long-term care residents. Many of us are familiar with how impacted the residents of long-term care facilities were in terms of deaths, in terms of morbidity, mortality, as well as hospitalizations. So we do agree with ACIP's recommendation to put the long-term care residents in a 1A. So these are some groups that we are focused on. This is not all-encompassing. There are other groups as well. And I urge folks to look up the CISA document, which is located on the website. And that's kind of gives you more of a definition of what the healthcare personnel group entails. So it includes hospitals, public health personnel, specifically those with patient care responsibilities, EMS and medical transport as well, pharmacies, home health, which also includes your direct service providers, as well as personal attendant service staff, long-term care facilities we already mentioned, and outpatient facilities as well. ACIP document, which is also on our website, really kind of gives you the rationale how that group determined these phases. So it's really nice to see that they looked at not just critical infrastructures, but they also looked at the science behind it, as well as implementation, as well as ethics. So across the board, they use that model to kind of figure out what groups should go in what phases. Next slide, please. So again, phase 1A includes you and your high-risk staff. Next slide, please. So this is where I'm kind of asking for your help. We are seeking your partnership to vaccinate all outpatient healthcare workers in Delaware. So there are many models involved, but what the key is here is that if you want to get any vaccine, whether it's directly from the federal level or from Division of Public Health, you need to enroll. And we're going to talk a little more about enrollment. There is no harm with enrollment. You are not committed to get vaccine. Again, you have to order vaccine. So if you enroll and decide not to participate, there is no harm there. My concern is that if you decide later on that you want to participate, there is some time needed to go through the enrollment process. So, my position is that, if you're even thinking about being involved in vaccination, whether it's just vaccination your staff or vaccinating patients, then you really should consider enrolling earlier than later, because there is some administrative time that's needed to get you through the enrollment process. So there are different models out there. So for instance, for individual practices, if you want to be independently responsible for your vaccine inventory, you want to be able to receive vaccine, you want to be able to control your inventory and report out your inventory, then you can enroll as an individual practice, and then you're just considered a vaccine provider. I also understand that there are other practices that may not have the support to be able to go through the enrollment process, the reporting requirement through Delvax, as well as your daily reporting of your inventory, that, there are some models out there that consider a hub and spoke model where you can partner with other practices and maybe designate a larger practice to be that enrolled provider, and that enrolled provider can support the smaller practices regarding vaccination. So there are a lot of models out there. So I don't want to have people feel like there's only one way of doing this, but I just want to be very transparent on what the requirements are. So again, you have to enroll. What you can do after enrollment is to receive vaccine directly through the federal level, or you can receive vaccine from the Division of Public Health. And then secondly, the other piece is that you will have to report daily. So you will have to report your administrations. And again, that's through Delaware. So hopefully most people are familiar with that process. But the second piece is you need to you need to report your inventory on a daily basis. So those are your two reporting requirements in relation to the enrollment process. Step two, or option two, we're working closely with pharmacies to set up closed pods for outpatient staff. And we have had great conversations with pharmacies. Many of the major chains are interested in being part of this process, whether they are going to open their stores up for vaccination, or they could potentially become vaccinators to closed vaccination sites. So whether they could go to an essential business and vaccinate staff, or they can even go to a practice and vaccinate staff, whatever the case is. So we do have pharmacy partners that are interested to provide those services. We are talking about voucher system would be examples. So, we would ask essential businesses to provide vouchers to those staff that are considered highest risk within their organization, and they could bring the voucher to pharmacies, and that'll be their ticket to get a vaccine. So there are very many miles out there, and we're still working on all options. So again, this is an opportunity where we can share best practices and learn from each other how best to do this. So we kind of talked about also option 3 to set up closed pods. So these are mass vaccination sites where many of you might be familiar with that we use during flu season, where we have either the drive-through or some other more open pods than what you see in businesses and so forth and so forth. So all these are kind of in the works and options. Ultimately, the goal is we want to use the normal vaccine delivery chains and channels to be able to get vaccine to the public. So that will mean urgent care, that will mean doctor's offices and FQHCs and pharmacies as well. So we would eventually like to get to that point once the supply is available. But until then, we kind of need to consider these other options to make sure that the vaccine is going to those that need it the most. Next slide, please. Next part of the agenda is how to become a vaccine provider. And, this is something where I've heard from the medical community that this is a little bit unclear of a process. So I'm hoping that I can kind of clear that up a little bit. There is additional information on our COVID vaccine website, and hopefully I'll remember to give you that address later, or the Academy can share that as well too. The website is very helpful that you can get the most up-to-date information regarding information about vaccine and so forth. So to administer the COVID-19 vaccine, again, I mentioned this already, that providers must complete the enrollment with our immunization program. So you need to enroll in 2 different programs, Delvax, which most of us are already enrolled, but that also will trigger enrollment in a federal website called Vaccine Finder. And that's where you report daily your inventory. Eventually, what the federal level would like to see, and similar to flu vaccine, is that people can Google and be able to search, where can I get the COVID-19 vaccine? And from there, that you'll be able to identify what sites are available for that. So again, each site must register for Delvax and complete the COVID-19 specific enrollment items. What is enrollment? Enrollment is a process by which all administering organizations, sites, and receiving personnel must register with the Delaware Immunization Program. Why is enrollment important? Because the administration site will not be able to order or administer any vaccine without completing the enrollment process. So again, we want to get as many providers enrolled as possible. And if once you enroll, you are not committed to order vaccine or to vaccinate anyone. But I think there is more harm waiting, because there is going to be some potential delay just going through the enrollment process. So kind of keep that in mind. If you are thinking of vaccinating anyone, then please enroll. And thank you, Kate, for those websites. Who needs to enroll? As I mentioned before, all administering sites who are going to be reporting inventory. So you kind of have to figure out how best to enroll, but you may have to enroll multiple sites. So a good example would be a pharmacy chain. If multiple stores have interest in vaccinating, then each store will be responsible for its inventory. So each store will need to enroll separately. What does enrollment entail? It's a multi-step process. It involves the following: a survey, and then you need to make sure you're registered for Delvax. You need to designate key vaccine administration roles. Typically, it's a CMO, as well as a fiscal person as well. You need to complete the CDC training module and then complete the provider listing and storage forms, so you can attest that you are able to store the vaccine safely. Multiple people have had different experiences with the enrollment process. It should take approximately 30 minutes as long as all the information is correct and there's no need to go back and forth revising the application. And then there's about 5 to 7 business days to get through the process. So just kind of give you an idea how long it may take and setting expectations of when you can start vaccinating. If you have any questions, the best way is really emailing covidvaccine@delaware.gov. That is a resource email address for our immunization program. That will be probably the best way to get your questions answered if you have any issues as well, or you can contact the immunization program directly by phone. Next slide, please. So your step-by-step guide is available on our website, and this was created because we did get some feedback that the enrollment process is cumbersome. So we tried to make it as easy as possible, and hopefully this slide presentation would help. It is located on the vaccine website. You can see there, that's on the slide. And hopefully these slides will kind of help you through the process. Next slide, please. And talking about guidelines for administering the vaccine, next slide. So this is a nice summary of the vaccine. I've already seen a couple questions asking about specific details on each vaccine. So hopefully this slide will help, and I'll be happy to answer other questions as well. So right now, all 3 vaccines, and we're going to talk about AstraZeneca just a little bit. Again, it has not started the EUA process yet. So all these vaccines require 2 doses. For Pfizer, it's 21 days apart. There is a grace period for 4 days, so you can technically get the second dose in by day 17. And then you can see Moderna, it's 28 days apart. So we did get comments from the CDC, and their recommendation, if you can't make it exactly on day 21, day 28, that's okay. We still would like the second dose to be administered as soon as possible if you can't make it on day 21 or day 28. And there's no need to redo the 2-dose process. So, you know, if it takes you a little bit longer to get the second dose, we want patients to know they don't have to start over. So you just get the second dose whenever they get in. And that should do it in terms of completing the series. On-site mixing is a good question. Now, Pfizer requires mixing on-site. There is a diluent that's provided with the vaccine that comes with the kit as well. So if you are going to get any vaccine, that you will also get ancillary supplies. So if it's the Pfizer, you'll get a diluent. It's a 2 ml normal saline diluent, but you're only supposed to use 1.8 milliliters. And then you'll also get syringes, you'll get needles and syringes, you'll get alcohol pads, you'll get gloves, a little bit of PPE as well too. So that will come with the vaccine to help support the additional expense of getting other supplies needed. For Moderna as well as the AstraZeneca, you do not need a diluent, so it's already going to come in already reconstituted. The storage requirements, I kind of want to focus a little bit because I think a lot of people are concerned about the storage requirements. The Pfizer is the more challenging one. You require ultra cold chain storage, which is about the -60 to -80 degrees Celsius. If you have that, and it's actually not up to 6 months, it should be up to 30 days you can store it. But I'm hoping no one's keeping it in ultra cold chain for as long as 30 days. You know, this is just a temporizing measure until you get your operations together to be able to release the vaccine. It can be stored in thermal shipping container up to 15 days. You can re-ice it every 5 days. So kind of picturing that, you know, there are pictures, I believe, on the website, and it was a really cool experience when you see it. So it comes in this vaccine shipper. It's basically a cooler, and it's got a temperature monitor on as well too. So when you open up the box, you actually see on the top, there's your dry ice, and it's what the dry ice is keeping that temperature at that low level. And then once you lift the dry ice, you actually see the vaccine, which are boxed in doses of 975 or 195 vials. So that's the minimum order you can make for Pfizer is 975 doses. And you can imagine that is somewhat challenging because not all practices or locations can use up all 975 in an appropriate amount of time. So those are one of the reasons why the Division of Public Health is receiving vaccines so we can break the tray and be able to distribute to multiple partners and not forcing one partner to absorb all 975 doses. So once you are ready to go vaccinate, you have an opportunity to change from the ultra cold chain to refrigeration of 2 to 8 degrees Celsius. So that's more, I guess, reasonable or more practical for typical practices and locations that they should be able to maintain vaccine in that range of 2 to 8 degrees Celsius, but you only could keep it in that storage for 5 days. So if you get any vaccine, Pfizer in particular, and it comes in refrigeration, not in that ultra cold chain, you have 5 days or 120 hours to use up that vaccine. If it surpasses the 5 days, the vaccine goes to waste. And that's why it's so important from a planning perspective to know that what the limitations are with the vaccine and what your timeline is. Once you take a vial out of refrigeration, it should have 5 doses. And recently, we have received reports that you might be able to get a 6th dose or even a 7th dose. The FDA allows the 6th dose as long as you have the 0.3 ml necessary for a complete dose. So don't shortchange anyone. But if you so happen to have 0.3 mLs in the remaining vial, then you can use it as a 6th dose. But once you reconstitute the vial for the Pfizer, you have 6 hours to use it up. So this is, again, a challenge that we can't just send out vaccines to everyone because you think about the ultra cold chain storage and then the refrigeration for 5 days and then 6-hour expiration once you reconstitute the vaccine. So a lot of challenges there. And hopefully that will kind of paint a better picture of why this is so difficult of a vaccine to manage. It's not simply something we could send out. But you can imagine, for instance, if there's a practice that wants to vaccinate its staff, we potentially could send out a couple of vials to that practice, and I hope that the practice can complete the vaccination of staff within that 5-day window. So again, there are some opportunities for there regarding that. Moderna does not have that ultra cold chain component. You can choose to freeze it at -20 degrees Celsius, and you could keep it in that freezer for 6 months. However, for use, you can put it in refrigeration between 2 to 8 degrees Celsius, and you have 30 days of taking care of that. So again, a lot more flexibility with the Moderna. So I anticipate when you're talking about practices and you want to use it for patients that the Moderna might be a better choice because you have more range of the 30 days and not the pressure of getting all your doses in within the 5 days. So, again, something that we're thinking about as well, how to accommodate practices to get the vaccine out to patients. Room temperature vaccination is up to 12 hours. The order size, we kind of mentioned with the Pfizer, 5 doses per vial, but you potentially get a 6th dose as long as you have the 0.3 mLs available for that 6th dose. And each tray contains 975 doses. And that's your minimum order is 1 tray or 975 doses. Again, a lot more flexibility with Moderna. There are 10 doses per vial, but each tray has 100 doses. So more manageable for, I think, most of your purposes if you plan on vaccinating your patients. Next slide, please. Data is important. So we are creating a public-facing website, very similar to My Healthy Community. Hopefully many of you guys are aware of My Healthy Community. That's our public-facing website to be able to share information and our progress with COVID-19. Those have metrics including hospitalizations, tests, deaths, and demographic information as well too. So we're kind of creating a website very similar to that, talking about vaccine metrics. So some of the data objectives we have, we want to track data to comply with CDC and state requirements. We want to track vaccination progress over time to make sure we're doing a good job, making sure we are getting vaccine out there. We all have to remember we are in the middle of a pandemic, so time sensitivity is there, and we want to get as many people vaccinated as possible. So again, balancing who to vaccinate, but we want to vaccinate as quickly as possible, balancing the challenges of storage, challenges of the expiration, and so forth. So again, just kind of painting that picture of this is not your normal vaccine that we can just, take out of the fridge, inject, and potentially put back in the fridge, and so forth. So it's very different from the flu vaccine. We want to enable inventory management, limited supply. Very critical initially. We want to make sure that all the doses are being used. So this is why that daily reporting is there so that people can identify what sites have inventory for the vaccine. And the other challenge is that second dose. So how do we make sure that people come back for the second dose? So there are reminders that can be sent out through Delvax. I'm sure many practices, many providers have their own system for second dose reminder. And then there's the traditional vaccine card that comes with every vaccine. I actually got vaccinated yesterday. It went fairly well, and I got vaccinated out of state because I'm a priority as a physician out of state, but I don't practice here. So I went to another state to get it through my workplace, and that worked out pretty well. And I took a picture of my vaccine card, so that was someone recommended that for me. So just kind of tell your patients, when you get a vaccine card, take a picture of it or something so they have the information, not lose the card. This is something also of concern that I heard is the CDC requires 22 different data elements to be captured for each administered dose. This is probably more than what typically is needed for other vaccines, but this is critical to get all 22 different data elements in, particularly the one that we are emphasizing, race, ethnicity. As you can imagine, it's critical that we have that information, and we do track that on My Healthy Community regarding testing, as well as biostatistics, and so forth. So we would like to capture that field as well too. I've also heard from many of the partners that their EMR may not be set up to transmit race and ethnicity. So just please check to make sure if you're using your EMR to report through Delvax that they are able to transmit race and ethnicity data into Delvax. All these fields are currently in Delvax, which is good. So for those of you who are familiar with Delvax, nothing has to change. Again, the EMR, you need to make sure that they can transmit all 23 data elements, specifically race and ethnicity. Again, the reporting requirement, to repeat, important for vaccine administrators to capture complete data and submit within 24 hours. Next slide, please. So there are 3 ways to capture the information. Again, we are using Delvax regardless. So either you directly input data into Delvax, you use your EMR system. Again, make sure race and ethnicity can be transmitted through your EMR system. And you can also use an Excel spreadsheet entry. You can complete all fields within the flat file template, which will be provided to you, and you upload into Delvax. So a couple of options you have here. Regardless of the chosen method, all required data fields must be completed. Next slide, please. We kind of went through this already with second dose reminders. Again, if you just have your first dose and don't get the second dose, you really don't get that efficacy, or you don't get that time coverage that you would get with the second dose. CDC has recommended that, the 1 dose doesn't help too much. So really reinforce to your patients that you need to get both doses to really get the maximum benefit from the vaccine series. And you kind of see here how we types of second dose reminders. We had the vaccine record cards, we had the reminder letters, and then automated phone calls and text messaging, and then whatever system individual providers may use. Next slide, please. There are various toolkits and other resources available. It's on the CDC website to support you. We also have some tools on our website, so feel free to use both resources. There are toolkits for medical centers, clinics, and clinicians. That's on the CDC website. Also, I think the messaging is very important, and that's one thing we spend a lot of time on, is really the communication to address vaccine hesitancy, and of course the fear of safety issues and so forth. So there are toolkits for that, and we also have information on our website. And then the vaccine storage and handling toolkit is also available, as well as on our website. So a lot of information, but hopefully this presentation will eliminate some of the fears. I heard a lot of concerns, and I hope that this will kind of give you more of a reason that you should participate in the vaccination program.